work from Mary Grove College in Detroit, Michigan, and her master's of social work at Wayne State University in Michigan. And like I said, she's currently right now over at the ETSU Physicians and Associates in Building 52 with us as one of our outpatient therapists, and also she's very involved with teaching the residents with regards to CBT. So please, let's give a warm welcome to Ms. Beverly Ray. Thank you.
Thank you. So today we're going to talk about, eye movement desensitization and reprocessing, also known as EMDR. I'll read our disclosure first. So neither I nor any members of my immediate family have a financial interest, arrangement, or affiliation that could be perceived as a real or apparent conflict of interest related to the content and supporters of this activity. My goal today is to try to give you a very condensed version of a 5-day intense training that I did take on EMDR back in June. So I'm still new at doing it, practicing it, but my experience has been pretty amazing. So we're going to define what EMDR is, who founded it, or what model it's adapted from, known as the adaptive information processing. And we'll talk about treatment approaches. And I have a colleague who attended the training with me, so she's going to share a little bit on her experience with that, and then a case example. And be prepared, because I'm going to ask you all questions at the end of our presentation. So EMDR, it's an evidence-based psychotherapy which was used originally just for PTSD, post-traumatic stress disorder. There are successful outcomes and very well-documented literature of other psychiatric disorders that are currently being treated with in EMDR. It's an 8-stage, 3-pronged process, which includes bilateral stimulation, and it triggers the conscious and unconscious memories. And that's kind of complicated, but we will have a little bit more of a definition on that. So EMDR, it's based on AIP, which suggests that most of the psychopathology is due to a maladaptive encoding or incomplete processing after a traumatic event occurs. A lot of times it gets frozen and just stays frozen, and current triggers can have flashbacks and such things. So this does impair our clients to integrate experiences into an adaptive manner. So the past is present, which negatively impacts people on their daily living and relationships. I'm sure if you work with people, sometimes they'll come in and say, you know, I've had a panic attack, but there was nothing that I could relate to why I had that panic attack. And usually it's due to a trauma in the unconscious mind that has been triggered. The origin of EMDR, so in 1987, Dr. Francine Shapiro made a chance observation that eye movement could reduce disturbing thoughts. It's kind of interesting because the only thing I could find on her experience was it says she was walking in a park with some disturbing thoughts, and she noticed that when she moved her eyes back and forth, that it decreased the intensity of those thoughts. So I would have loved to have heard or seen or known what those disturbing thoughts were. And so Dr. Shapiro, she did pass away June 16th or 17th of this year. Her work is what she did her PhD thesis on, and then in 1989 it was the basis for an article that she did in the Journal of Post-Traumatic Stress. Since then, EMDR has developed and evolved through therapists and researchers all over the world. So EMDR incorporates many elements from different treatment approaches, such as CBT, solution-focused, psychodynamic therapy. So being based on, as I said a few minutes ago, the adaptive information processing model, this is how it's explained a little bit simpler than what the extensive literature shows, but I thought this broke it down pretty well. So we have a traumatic event that happens, and the natural system when we process a memory is interrupted because of the high arousal and or the encoding as survival information. So the information that occurred at that time is the upsetting event, and it becomes frozen in the memory. So again, those present-day triggers or experiences can activate those feelings and responses in the stored memory. So they're persistent, intrusive thoughts. People can have the negative emotions, negative perceptions of self, and physical sensations. And again, that's something that we see frequently in PTSD. So I have a little video that may seem a little bit repetitive, but I was afraid that if the little video didn't work out, that I needed something else to be able to go by. But again, it's laying the groundwork with EMDR. They work with what we call adaptive and maladaptive thought patterns. So in the AIP networking, and also brain plasticity plays a part into this, we will see where those maladaptive memories are triggered through the bilateral processing, and then we would actually link that situation, the trauma, from that maladaptive to a more adaptive thought pattern or thought, which through the whole processing event, again, that lessens and updates that maladaptive thought. Whoops. So AIP distinguishes EMDR from other psychotherapy approaches, which is viewing the present situation and producing distress as a trigger of an unprocessed event. I think this is all pretty repetitive. So the last one, if the innate information processing system is impaired, the memory will be stored, again, as maladaptive. So I like this example. It's like working with a Word document. So you've got the document, it's developed in the computers, it's known as the working memory. And then once completed, the document is saved or consolidated, it's stored on the computer's hard drive. So then this document can be reopened, retrieved, and revised, and that would be considered the working memory. So once that's completed and saved, then the document is revised on the hard drive, or what we would call in the brain our hippocampus. And this little diagram over there to the right, you've got sight, sound, touch, would be the immediate memory or trigger. Goes down to the event. The triggers the event or the working memory to that long-term memory. So then the process of EMDR will allow the client to process the emotional experience. Again, uses that bilateral stimulation, which moves the eyes left and right, or tactile stimulation. I'll talk a little bit more about the different types of stimulation. So it's repeated and activates the opposite side of the brain, which then releases the emotional experience that's been trapped in the nervous system. It unlocks the negative memories and emotions stored. And then EMDR gives the clients the opportunity to gain self-knowledge that guides their actions rather than feelings of powerlessness to their reactions. I think that's really a big key with people that we work with. There's a lot feeling powerless over situations and really not knowing where that comes from. So it's amazing how our mind processes this on its own. And so in the EMDR therapy, the client internally generates corrective information about the event rather than information being externally generated through discussion. So it's very different from, sitting across from your client and talking through a trauma or an event. As the therapist, we don't have to reflect, interpret, reframe, or intervene in any of the traditional ways. It's client-centered. The client follows their own processing. And so in the midst of some of the bilateral stimulation, depending on what we're doing, the processing usually is anywhere from, or the bilateral stimulation is about 15 to 25 passes. So this would be considered 1 and then 2. So after about, you have the patient thinking about the trauma or the disturbing event and the negative maladaptive thought with that. And then as they process it, after about 15 to 25, you would simply ask them, what are you noticing? Or let's go with that. And again, that is the brain's working through the events of what had happened. And then sometimes they can get stuck, so you do some cognitive interweaves, such as, if they're stuck with their inner child, I've said, it's okay, let that child know what it is that they need. And as they think about that, again, their own mind processes where it is that they need to go. And so we have 3 different, what we call processing, I just call them modes, depending on, again, the trauma or the incident that's being processed. So there's EMDR, big R, which would be desensitizing the entire neural network. And you just allow the patient to process wherever they go. So they might have a current situation that is disturbing to them, and as they bring it to the table, let's just say they had an argument with a spouse and they reacted in a way that was very unusual for them. So as they process that, it may take them to other incidents and sometimes even back to childhood. And that would just be considered unrestricted processing. You just allow them to go wherever they go. And then EMDR little r, it's processing an incident with insights as well as desensitization. That word always stumbles me, desensitization. So you're going to address a maladaptive thought only around that particular issue. So if other issues come up or traumas from childhood, you redirect to current. Because again, you're just targeting that maladaptive thought on current and or recent issues. And then you have the EMDR up. And that's a specific target. They also call that contained. We only process that one particular event or trauma and nothing else. And that could be from the past or something current. And then we looked at, and I mentioned earlier, about the 8-phase protocol. So this was Dr. Shapiro's original format. So take a client history and treatment planning, client preparation, assessment, then your processing, installation, body scan, closure, reevaluation. So in the client history, what we're really looking for, And it's similar to CBT when you're looking or asking for situations that may have uncovered certain core beliefs. And from that history is where you're going to develop the treatment plan, which is also called a target sequence plan. And in client preparation, that would involve, one, educating them on EMDR. It would also be sure that they have the coping mechanisms or skills to handle the emotional, I'm going to say instability that they're going to experience from this. They just can become very emotional for even days following. So you just want to make sure that, we call them coping skills usually. With EMDR, we call them resourcing. And there's also extended resourcing. And these are the positive, they affect and continue to develop the positive neural networks to make those adaptive thoughts. Okay, your assessment, again, you want to look at, is this, for the target plan, are these the areas that you want to work on, and you're going to decide which type of EMDR that you're going to use. So then the desensitization is taking that client through the event as their mind processes that. So they're thinking about the maladaptive thought as it pertains to the incident. I've had someone who was sexually assaulted as a child, raped, molested, you can call it any of the above. And so the maladaptive thought that went with that is that, it's my fault. I should have done something different. So through the processing of that, you have them focus on the trauma, on that maladaptive thought, and so again, you do the bilateral stimulation, and their mind, we want to measure how intense their disturbance is. And usually, something like incident like that, you're probably looking at on a scale of 1 to 10, the disturbance as being, 8, 9, or 10. So as they process that, the disturbance, we'd really love to see that come down to a 0. But you bring that as low as you can and as low as the person believes it will come. And then that brings you to installation. And that is where we will link the trauma to the adaptive thought. So in the example that I gave, the adaptive thought was, it was beyond my control, but I don't have to let it define me. So again, you link that trauma with the adaptive thought through the same process as the bilateral stimulation. And the goal on that is, when you begin, you ask the person, how much do they believe that adaptive thought? And it can be anywhere from a 2 to a 7. But usually in a case like this, it's not going to get much above a 7. So you want to continue processing that until they believe, as high as it'll go, that this was in no way their fault, and that they are not going to be a victim, that they're going to be a survivor. So then the body scan would simply be where you have them close their eyes and just kind of scan throughout the body and see if there's any body symptoms that were related to the trauma, anxiety, anger, frustration. And if there is, then you process that emotion or that feeling within the body. Again, the goal is to try to get that all down to neutral or the belief of the trauma and the body sensation all down as low as possible. Closure, you want to discuss with them that sometimes the processing will continue after the session, could be a couple of days. They may be very emotional for a couple of days, but rest them assured that it's okay. And they also will have skills or the resourcing that they can use to self-soothe, to bring down any uncomfortable feelings that may come up. And again, we teach them at home how to do some of their own bilateral stimulation, which they can do by either tapping, so like on their legs they can tap, or, so I want to get everybody involved because they say you learn better if you hear, you look, and you try. So everybody, take your hands and close your eyes for just a minute. And just imagine a peaceful, quiet place and tap right, left, right, left. Okay. So that would be another way of bilateral stimulation. And we do want them to practice that at home. And again, there are other resourcing that we instill to prepare them for the processing. So there's the fingers, there's the tapping, which sometimes some people can't move their eyes fast enough or follow along. So either we will, with their permission, tap for them or on them. For children, they also have, they call them buzzies or tappers, which I still just use my fingers because, one, I don't have kids that I work with, but they tell us to wait a little bit till we get more familiar with using the stimulation before we invest in any equipment, and I do have some pictures of equipment here in a minute. All right, so again, now the three-ring process is you're going to process the past event in identifying core memories, earliest memories that laid the foundation for the problem, process present event, and future event. So what that would look like was once we have done all that adaptive thoughts and processed everything, you want to work with them on preparing themselves and learning to soothe themselves. Example, so that current event, you ask them, can they think of something that's happened recently that it would have been beneficial. I need to back up just for a minute, I'm sorry. I'm going to use this with a resourcing. So one of the things that we help the client to build, it's called a container. So the container in their mind is they build a box, a safe, whatever it is for them, that they will be able to put things into until they're ready or able to deal with it at a later time. So that would help some anxiety issues or upcoming events. So using with this three-pronged approach, we would have them process a past event and then a current event where their container would have been helpful for them to put the situation into. And then process a future event. So you ask them, is there something coming up in the near future that you think it will be helpful to have your container to be able to use? So as they think about past, present, and future events, you process each one with them and have them put the self-tapping in with a disturbance and they practice putting the situation into their container. I'm not sure if this is really clear how I'm trying to describe it. The whole idea is, though, you want to allow them to learn to trust themselves, that they can relieve some of their own distress from a past event, current, and then a future event. And so that helps develop those adaptive neural networks. If that didn't come out real clear, I'll be happy to try to explain it. My email's on here at the end, so you can always email me. So these are some of the tools that are used with EMDR. You've got the buzzies over on the left, and then the little guy that did the video, the fingers. And then in the lower right, there's also a light where the patient would follow the light. And then there's also tappers. I think there's a few other tools, but these are the main ones that I'm familiar with. So in processing the sessions, they're usually 50 minutes. Takes, again, the targeted memory can require sometimes more than one session to come to the adaptive resolution. Number of processing sessions really is individualized, depends on the client, the experience or the trauma that they experience, and their ability to grasp ways to be able to deal, apply the resourcing that they learn. So 1 to 4 sessions sometimes can be used for a single traumatic event. And then the processing may or may not continue, as I said a little bit ago, after the session. So strengthening resource neural networks. I've touched on that already. You want to direct the client's attention to already existing resources, which already enhances that positive neural network. And so I have a lady who, her niece and nephew is her, what I would call, quiet go-to place. So she's already had that kind of developed in her own mind. So what I have her practice at home sometimes is just that, thinking about those children and tapping in those pleasurable feelings that she associates with that. And for her, so far, that has allowed her to manage her anxiety, in a different way. We want to enhance and strengthen these resources, again, in the positive neural networks. Encouraging them, to practice these things on a daily basis, because as you know, the neuroplasticity can be changed, but it takes practice. And I've already mentioned at the bottom of here, they have the container, inner peaceful place, self-soothing. We have quite a few other resources that we try to teach them. And so, this is my co-worker, colleague, Susan Fields, who also attended the training with me. She's just going to share a little bit of her experience during our training.
Okay, it's on. Well, I want to thank Beverly for including me in this today, and just tell you a little bit about my experience. Probably about a month before our intensive training, and it was intensive for me. I visited my home place after probably a 40-year hiatus, and I had gone by an area. I was riding with my husband. I had gone by an area which absolutely triggered all kind of disturbing thoughts and perceptions and memories. And so there was a period of time between when I was 12 and 14 where it was a very, very dark period for me. And so I moved out of the area, finished high school, moved out of the area, and moved on with my life. So I was very, very surprised that I had that reaction, and knew in my head, but the same, I was overcome when my husband and I drove by there with the same thoughts and feelings and beliefs that I had when I was 13 years old. So at 66, that's been sitting there for a long time, okay? So talked to my husband about it. He was very helpful. Went on the next day, life as usual, no problems, okay? And so Beverly and I got to know each other a little bit just through email and planned on going to this intensive training together. And so we came together and trained. So what was triggered for me during that training was a lot of leftover stuff from those 2 years. And to have experienced that was something that I just never anticipated. The very, very, very strong emotions that came to surface, as well as some very, very troubling beliefs. And so going through that, it was like, if you're not happy about going through tunnels, okay, and you're in a long tunnel and you're in the car, it's like, oh my gosh, okay, I'm going to get through this. There is a light at the end of the tunnel, and you're through. Beverly did a fabulous job of taking me through that whole process. And so having integrated those things, I came up with thoughts and feelings that never occurred to me before, like outrage. For the first time in my life, I was outraged about what happened to me. And that felt really pretty doggone good. And the adaptive thoughts about, I got through it. There have been things in my life that I've missed, but then there's been successes in spite of. So I came out of there really wiped out. Feeling good, but like very, very emotionally tired, physically tired. And I processed that for a couple of days. So that was like midweek when we did that. I could not tell you how long that particular session took. This was the unrestricted EMDR. So do you remember how long that was, Beverly?
I don't, but she doesn't know this. She scared the kajibers out of me.
I bet I did. I mean, I scared me, but she was just followed that protocol and did a wonderful job. But more than that, whether we're doing EMDR or cognitive therapy or whatever kind of eclectic therapy your therapist might pull out of the bag, nothing is going to work if you don't have a therapeutic and trusting relationship. And so I knew that I could trust Beverly. And that is a big key. So I've been a therapist now for 28 years, and it's given me some personal insight, and I think kind of reinforced some things that I already knew, but it made them real. It's like you've got to really form a close connection with your client and go where they go, and understand that anytime, having revealed those very, very painful things about myself, that's a very vulnerable place to be. It was a very vulnerable place for me to be. And so I have a new respect for folks that come in and they're telling someone something for the first time. So I want to thank you all for letting me share that, and I especially want to thank Beverly because she was instrumental. It's been June since that was. I've been doing very, very well. Some of the things that would normally just rattle me, they're minimal now. So I'm grateful. It's a good practice. It's a really good tool to have in terms of your treatment. And just want to thank her.
Thanks, Susie. So this really isn't about me. I thank you, Susan. I think I just really want to emphasize it's the EMDR, and it's another way to be able to serve our patients, our clients, in another unique way that seems to go deeper and faster. And when we first took this training, I didn't think I was going to want to go on and get my certificate, but I'm going to. I'm pretty sure I'm going to go forward and do that because, like I said, this is an overview, and there's so much, and there's so many protocols that can be used, for a lot of different issues. And I have more of a list of that here in a minute. So I wanted to share a case example. So this is a lady that I've been seeing for quite some time, over a couple of years, and she's been widowed approximately 5 to 6 years. So she had multiple deaths within her family and close friends well over the course of 10 years. Her husband, though, proved to be the most disturbing for her, difficult for her. So when we first started working together, we did a lot of grief and loss work. So she came in not too long ago and had been, every time a anniversary or something comes up of her husband, whether it's a birthday, she even counts, their first date. I think they were married about 43 years. So it was coming close to the one of the anniversaries. And she had been thinking about his last couple of days of life. He was in ICU, and he had had cancer, terminal cancer. And she knew, he would be dying soon. And they had talked about that, and they talked about what his wishes would be. And he did not want to remain on any life support if there was, no hope or for a quality of life, and he was not responding. So up until, I believe, about a day prior to him passing, he had been able to make, eye contact with her. And he was on life support, so, they continued that. And then when he was no longer able to communicate, she had to make the decision, to take him off of life support. And it was a difficult thing for her to do, even though, that's what he had expressed he wanted. So ultimately, she did what he'd asked and had him taken off life support, and he passed away. But it's always haunted her in memories of, did I do the right thing? Should I have waited any longer? And could he have actually been saved and come back? And, those are extremely difficult things to think about, to be responsible for, and it just was very disturbing and very emotional for her. So the day that she came in, we decided to do some EMDR on that. And so the maladaptive thought was basically what I already stated. Would he still be alive today? Should I have waited longer? Excuse me. And feelings of guilt. So her adaptive thought was, I know I did what I needed to, and that's what he wanted. So this was probably more emotional processing with her than what Susan described her experience was. But we contained it to this one incident. And, you know, as much as I want to say, you know, when you talk with your patients, and you can sometimes get emotionally charged in, you know, talk therapy. For me, I find also that I get emotionally charged as they process their trauma, even though I don't know necessarily what's going on for them in their mind. It's just amazing. It's sad, but also joyful, if that makes sense. So she did the processing, and that level of disturbance connected with that thought, we were able to get down to a 2. So we linked that experience to the adaptive thought, and we processed that. And, you know, it's funny because, again, even though I'm not talking to people, I'm beginning to learn how to read their body language and different, you know, facial, like, quivers or something. And so after we got done processing and, you know, we did the closing and everything. But she was able to get she believed the adaptive thought. It was an 8 and a 9. So to this day, she's not disturbed by it. She can think about her husband. She can think about end of life, and she can even think about, you know, making that decision and asking the doctors. But she's sad, but she's not, you know, that disturbance of it has definitely updated and been revised to a more loving memory that she was able to do, you know, what he wanted. And I said a few minutes ago that, you know, I got a little bit nervous or scared when Susan and I were in our training. So the first couple of EMDR people that I did with the emotional, I went ahead and gave my cell phone number and said, if you have any issues, give me a call. And this particular person, I actually called her when I hadn't heard from her just to make sure that she was doing okay. So anyway, she allowed me to share this experience with all of you, so I was grateful for that. All right, so now we're looking at what other things EMDR has proven to be helpful on. And there's a whole lot on there, so I won't go ahead and read each one, but each area up here, there's also specialized protocol training that you can take. So that's the reason I'd like to move forward with, you know, getting my certificate and being able to be more informed on how to do certain protocols. With somebody else in, what's the word? Amputate, I didn't want to say cut off. That type of patient, SAMHSA, International Society of Traumatic Studies, there's a whole lot of research. And again, when we're done, my email will be here if anybody wants further information or research. They're welcome to it. We have just a couple of minutes. I'm going to ask Emily if she would come up here for a minute. And this is an MSW intern that I have. And she said if we had time, she would be willing to do this for me. So I'm not just calling her out of the cold. But Emily sits in with me with some of my people that are willing for her to. And I just wanted her to share briefly what she experienced as she observed me doing some EMDR with people.
Okay, so one of my first days at internship with Beverly, she did EMDR on one of the clients that are more straightforward, and I was almost intimidated by him coming forward. But he was affected by an experience that what would be not so maladaptive to us. He forgot to leave a tip to his waiter a week ago, and he was still upset by that experience. So then Beverly performed EMDR, and just as an observer, I saw a tremendous difference in him, and I saw that he was able to cope with that experience, what would be simple to us. He was able to better process it in just a matter of a few minutes of doing EMDR with Beverly. And there's been a few instances where I've seen Beverly do EMDR, and almost every time that I have seen her do it, I saw a difference. And of course, she has emphasized on some of it takes a few sessions to fully get through that experience, but I do see a difference in the way they process that from the beginning to the session to the end.
Thanks, Emily. So, anybody ready to answer some questions? All righty. So, Preston. I'm going to ask Preston. How long does EMDR take? No, Dr. Tadapelli. Preston's down here. I want him to answer my question. I told everybody be alert. I was going to ask questions.
So, up to 12 sessions?
Very good. You seem like the answer was right there for you. Who knows what bilateral stimulation is? Nobody? How about Dr. Jensen?
So, bilateral stimulation just means some kind of sensory stimulation on the left and then the right and then alternating.
Yeah. You got it. So I guess y'all stayed awake for me. Well, yeah, we'll go to that in just a second. I just wanted it for resources. If you want any further information or questions, this is my email. Did anybody have questions?
Not want any deliveries happening right here. Okay, so I have a couple of questions actually. One is, I just want to be clear, when you went through your various phases, so are you doing the tapping or the eyes during the desensitization, restoration, and consolidation during all three phases, is that correct?
Yes.
Okay, that's great. The second thing I wanted to ask is these two patients that you mentioned that we're sharing, you talked about. For the first patient, she got better, but when she gets the next anniversary of something, his birthday, their marriage, or whatever, will there be some regression in terms of those symptoms, and will you need to repeat maybe another session of EMDR? And the third question is, the initial training you did, how long was that? I mean, I know there's subspecializations within different things you can do.
Okay. So the patient regarding her husband, that particular incident has been at this point resolved. Is it possible for something else to trigger that particular incident and disturbing thoughts? It is. And will we do another session? Absolutely. What I found in working with this particular person is in most aspects of her life, she's been able to accept the death of her husband and does not have the intense, disturbing thoughts and feelings that were connected to taking him off life support. But if she does, yes, that would be something that we could most likely do the contained EMDR, which would be around that specific incident. There was one more. Okay. So we had, usually the EMDR training is in 2 phases. What we went to was combined phases, 1 and 2, and it was 5 days of intense training, followed up by, we do the 10 hours of group consultation in a period. We have up to 2 years, but I think I've got 2 more to do.
Hi, thank you for sharing this with us all. I am a clinical psychologist and teach our graduate students about our evidence-based treatments for trauma and do a lot of teaching around prolonged exposure and cognitive processing therapy. And now, of course, this one is also in that list. And one of the things I'm seeing a lot in the literature is debate around whether this works because it's just a different way of packaging exposure therapy, and that the bilateral stimulation is not actually an essential treatment component. It's more about the processing of the trauma and that exposure to the trauma memory that's the mechanism of action. And so I'm just curious about your thoughts on that debate.
Well, one of my slides, maybe I passed it up. I mean, there's ongoing research, and there's controversy probably over a lot of different issues or treatment approaches. I have not read anything that said it's just about the processing it. And the bilateral stimulation, it's something about the back and forth of both sides of the brain that become involved in the processing. And honestly, that's about the best answer I can give you. So you're welcome. Anybody else? All righty. Well, so references, and looks like that's it.
Thank you so much, Ms. Ray.